Brenden Fowkes is a global industry technology leader in healthcare from IBM. He has 25 plus years of healthcare experience across payers, providers, and governments, provide a unique viewpoint on the industry. His previous roles include a progression from electronic medical record development and implementation to revenue cycle business process optimization to analytics consulting. This allows him to easily bridge the gap from the executive suite to the technical solution design and deployment for any healthcare business challenge. As a member of the global healthcare team, Brenden is able to bring innovative and proven use cases to his clients to help accelerate their time to value, analytics-driven initiative, including examples in conversational AI, real-time ICU monitoring and predictive modeling to prevent post-surgical complications. Welcome, Brenden, to our workshop. It's our pleasure that you find time to give a talk in our workshop. So the stage is yours. You can share your screen and go ahead. Thank you.
So excellent. I have some content. I'm going to share my screen momentarily with everyone. So once again, thank you for inviting IBM to be a part of this. We're humbled to share our point of view and what we see in the industry. I think our partnership with academia and workshops like this is really, really important as we develop new talent for the new generation. So again, we enjoy. I'll be at George Washington University, the Millikan School of Public Health on Monday. Monday? Yeah, I'm going to a meeting with the Veterans Administration. They squeezed me in to teach a class that afternoon somehow. I'm not sure I got volunteered into that one, but these things happen in a good way. So let me share desktop. Let me share the right desktop. I want that one. Share. There we go. That didn't work right. Oops, sorry about that. You told this in slideshow mode. Can everyone see that okay? My business. All right, cool. So I have a couple of topics here to walk through, and it was good I was able to jump on and hear the last half hour or so of Troy's presentation from the FDA, which is really helpful. So a little bit of what we're kind of seeing, successes, challenges, and what, as your organization is thinking about training this next generation of students, plus there's some other great speakers here from other places, what we're seeing at a macroeconomic level. And as you shared during the intro, so my role is to set the strategy for how healthcare organizations on a global scale use our technology to solve business problems. If I spin things from a clinical point of view, it's not because I am one, it's because my mother was one. So I was raised by a nurse. I just didn't like biology. So I ended up in computer science and physics and came to healthcare IT that way. Kind of like when Troy, I heard him say something about mid-90s. That's about when I started this. Pretty soon enough to change my 25 plus to 30 plus, which makes me sound old. But what we're going to do is hit on this a little bit. Some of the things people are thinking about, why this hasn't taken off. And some of the stuff I have is stats from a presentation I recently did with Gartner on the topic. And then with the use cases, the fun stuff. And I think that's a good part of it. And when I did this about 2 months ago, I'm going to probably end near the end. I was an interviewee in a fireside chat style, which is way more fun. And the way we ended the talk was, when they figure out all these problems, what if? What would be the dream scenario? At that point, I take my IBM hat off and I think about it like a technologist in healthcare. So, as we think about this, and this is a global problem, no matter how healthcare is funded and financed. I was on with the UAE this morning, then I was on with Ireland. Yeah, Ireland. No, Madrid, sorry. He was an Irish guy in Madrid. Sorry, that's what threw me off. So I've been bouncing time zones today. Regardless of the economy, whether we're here north of the border, we're in Ireland, we will do a lot of work with the NHS, UAE, Dubai Health Authority. A lot of these problems are still the same. How do we shift and focus on that quadruple aim of improved quality, lower costs, better access, and a better experience, but not just for the patients and members, for the caregivers. These are the important topics that we need to think about as you try to break them into various buckets. As you think about the AI buzz or generative AI, whatever word you want to think about, there's opportunities in here everywhere. But the key is, if you're going to study something and build any type of model, what are you going to automate? There's been great projects. Like I said, I've been in this industry a long, long time, along with some of these speakers over the next few days, yes, today and tomorrow. We've seen these great things that never achieved the value we hoped they would. I jokingly call it pilot purgatory. That's a Brendanism, not an official IBM statement, because people had the best of intentions, but didn't understand how to operationalize their idea. And what were we going to automate, and the ROI that goes with it. These are the bigger pictures. This has nothing to do with tech. This is how you think about these use cases. And I think it's really important as you go partner with organizations, whether I'm going to be in Nashville. I still have to book my flight. I'll be there Friday morning to have some of these conversations too, is as you go to partner with medical institutions, with health plans, with life sciences companies, as you're starting to walk through this, and Gen AI is what everybody wants to talk about, you have to remember to help them reset. What are we going to do, and what are we going to automate, and what's the benefit? So what I tend to do, and you guys can take this, now I know this is an advanced audience, but the way I try to do it, and I did this with TRICARE, which is part of the Veterans Delivery Organization. So our veterans don't always have to go to the VA, because sometimes there isn't one nearby. TRICARE helps administer this. So when I sat down with their administrative staff, they got excited. I said, okay, guys, let me help you understand buzz from what you can actually do. It doesn't all have to be Gen AI, because there are uses. And as you know, there's so many data scientists on this agenda and whatnot. They're very different techniques, and there is not a one size that fits them all. So helping your constituents, your partners, understand the difference is going to be an important part. So we just put them in terms of, this is old-fashioned reporting. You can call it whatever you want, but it's really just reporting. People still need this. Machine learning, this is where we get into this part of understanding and predicting something. Obviously, deep learning, you take it to the next level, and then foundational models, and giving them examples that they can really use will be helpful as you work with other people too. I find a lot of business owners, a lot of C-level executives, other than CIO or chief data officers, this mindset, this can we explain the difference in what each one's good for, is a great level set. It's a good way to look at it. Now, by the way, we've done all of these use cases across the bottom. I just happen to pick ones we've done, because I can speak to all of them because I've worked on all of them. So if anybody wants to dig into any one of these, feel free to let me know. But at the same time, we immediately start to get into the conversation of transparency, transparent AI, ethical AI, whatever word your organization or an organization you work with wants to use. We come down to these discussions very, very quickly. And what we help people understand, I'm actually going to skip out of order on my own slides, is that we've actually created a model around principles and pillars. So this is a live link. So Francesca Rossi is our Chief AI Ethics Officer. IBM saw this coming a decade ago, and she's been in this role, I think, for 9 years now, if I do my math correctly. This is a live recording of her, just 25 minutes or so, of walking through how to think about this. Now, Dr. Rossi, PhD Dr. Rossi, was consulting on the EU AI Act before it was even written, and now went into law a week ago. She's consults with the World Health Organization on how to roll this out. And then I was able to, there's a couple other links, we call them Tech Talks. IBM researchers, these are people that do research for research's sake still. not anything to do with our stuff. People from around the world that talk about 5-minute to 10-minute talks on what did these 5 topics mean and how you take them together to put them into practice. I know there was an ethical AI talk when I joined. Troy was talking about some of this. And I think one of the things that's really, really imperative is collaborating with organizations like yourself, because the people that need to work on these projects need to be as diverse as the data is. And this is one of the things we go out and tell people how to do and what to do all the time. We want to go look at your data science team and say, boy, that's really, you may have challenges. We have the ability to say that things that make people uncomfortable because your team's not diverse enough. Forget about your data being diverse enough. We'll help you. Technology can help you study and monitor the data, the parameters, the millions of parameters from the last question. But you need a team as diverse as your data set is what we highly recommend as a big part of it, because as humans, we all have we try to realize our biases, but they're hard sometimes. So my accent didn't give me away. I'm from Boston. So I think anybody that likes the Eagles is crazy. So you can make a joke out of a sports bias, but it's one of those things. It's funny, but it carries through. So it's one of, as you go through life, you have to start to recognize it. We, as a company, it's something we train people about all the time, regardless of your job. Doesn't matter what you do here, you go through massive diversity inclusion training because you need to recognize this in yourself to do your job better, regardless of what your role is. So as you walk through these, this is really important. I wanted to just jump ahead to this. But I think that's why, as much as the buzz is happening in the industry, and I've been with chief analytics officers at health plans, there's a very large health plan in the Midwest. Chief analytics officer said, she was telling me, she's like, one of the board members called me. So this was last May, June. So the buzz is happening. She's like, I had a board member call me and ask me how we were going to use ChatGPT to solve all our data problems. She goes, I don't think this guy owns a computer. But the buzz is like nothing I've ever seen. I'm old. I saw the web come around. This is so far beyond that. This is like the invention of the telephone or electricity. Like it's such a shift. It's beyond just, Netscape hitting the street. In my mind, everybody wants to adopt it. But according to combination of some of the work that we've done, this is not the Gartner study one. This is actually, we have something called the Institute for Business Value. So we go out and survey, I think we did 5,000 C-level executives around the world in every industry. And we're trying to understand, where is everybody going and why aren't they going fast enough? And it's obvious that they don't feel the data is good. They don't have maybe the right team. They may not have the skills. They don't have the data. They don't understand. They have problems with data lineage now. Trying to push it into real time takes it into a whole nother level. I tend to see, I joke about it, like all the problems we have with data and data lineage and data quality in healthcare, because it's messy. All Gen AI is just expose that we never fixed the plumbing. We never fixed the foundation of the house. And we're worried, we already want to put an addition on with Gen AI, but the house is going to collapse because we didn't pour the foundation correctly. I also grew up working construction, so I apologize for any construction analogies. They come very natural to me. So as we think through these are the things you're kind of facing. So beyond the ethical pillars, the things to think about from AI, Gen AI, once again, no technology, no use cases yet, is kind of this concept. Open. There is no one ring to rule them all yet. The market's moving too fast. We're making mistakes along the way, which is fine, as long as we don't do it in our industry. Have fun making mistakes in banking and other places. Don't do it with my patients. But it needs to be open. You need to be able to use everyone's technology. Be able to choose which model is right for you based on your use case. Somebody else's model, your self-developed model, big one, small one, whatever it may be, one that's good at language translation, one that's better at generating customer service. We don't care. You need to be able to be open about it. The other thing we're really seeing is cost, targeted. I was talking to a small, one single state, not small, they're pretty good size, health plan. One of their brilliant data scientists, and I've met him numerous times over the years, started working in their Azure environment with OpenAI. And he ran up almost $500,000 in unexpected cloud costs, messing around with his tokens and trying to tune such a big model. That's a lot of money. They're not Humana, they're not Anthem, they're not any of these big ones that happen that, they're spending $10 million a month with Azure and AWS anyways, and they wouldn't really notice that. So when you're thinking about this, think about targeted. What am I trying to do in which model? And can I just train parts of that model? So think about targeted and trusted. Trust, transparency. Obviously, there was a whole topic earlier on ethics. You can tell I'm a little passionate about this topic. But the other thing, back to open, what we're really seeing, and you'll see this too when you talk to folks and your internal teams that are working on cool innovation research projects, is that just because you use one piece of tech to build it doesn't mean you should use the same one to monitor it. The healthcare ecosystem is sending each other RFPs asking what is their AI governance strategy and technology over the top of any use of AI right now. Now, the regulations aren't there. We have all these discussions. I am not a regulatory expert. I study them and I keep up to date. Our chief privacy officer, Tricia Montgomery, she's testified in front of Congress before. I talked about Francesca Rossi earlier. We have people that do that. I'm not going to pretend to be a legislator, but I'm telling you what I'm seeing in the ecosystem is if you're using AI, I want to know. And this is everywhere. Employers are sending that question to health plans. Health plans are asking vendors. Hospitals are asking vendors. Vendors are asking other vendors. So there is this concept of I use one tool to build it and a different tool to monitor it. And think of it as if Deloitte does your consulting, they can't audit your books. Thank you, Enron and Arthur Henderson back in the day. How do we become your bank regulator for the stuff you're already building? Because everyone's already doing something. Everybody's going fast, but small. And then empowering. How do you make this easy? The whole point is to automate something. How do we get this to the end users where they trust it, that they feel empowered to play with it? Because with the right front end, the end users are the people that are going to tell you whether you got your model right or wrong. I said, I've been in healthcare IT for almost 30 years. I would never say that I could build a model better than what a nurse is going to do or a doctor is going to do standing over a patient. I think of it as the science behind the art of medicine. But if they're empowered, they will use it. If they trust it, you can do it efficiently because you use the targeted model, cost effective, and it's open, and they can see it. Hey, we think Brenden, he was on earlier. Troy was talking about sepsis. That's the holy grail. Predicting sepsis in real time. It just never kind of works. No one's really, really got it right for a lot of reasons because it's really, really hard. But regardless, even if it's a simple one, hey, 3 months from now, we think that Brendan's going to end up in the emergency department with an unplanned diabetes event. Okay, why? You better very quickly explain what changed in order to do that. So these are how people are thinking about it. I'm going to jump into the fun part, the use cases, what I'm seeing other ones in the industry. Any questions on kind of how we're thinking about that? I don't think I can see the chat. I'm not a Zoom expert. We still use WebEx for some reason. Feel free to weigh in as we go. I'm always happy to break up dialogue along the way. Hop up to here. All right, so I will jump in. I'll take silence as there was nothing there. Use cases. And I'm going to go into a couple of these in a lot more detail. The biggest use case right now is retrieval augmented generation in any of them right now. There is so much documentation, so much paper, it's digitized mostly. There's so much documentation for people to read and understand that it's almost impossible. Like I said, I've been in this a long time. There are times I read my benefits summary and I scratch my head because I'll read an EOB because I'm a healthcare nerd. Most people don't. So when you think about all of these steps along the way, whether it's patient member support, whether it's note summarization, whether it's some of the really cool ones, and I don't think I put it on here, which is unfortunate, I didn't update it. The other big thing is they're going to put an ambient microphone either on the table or up in the ceiling. And you and your clinician can have a conversation about your health and wellness. And the dream is that this thing updates it automatically into your electronic medical record, Epic, Cerner, Meditech, Athena, whoever's still left these days anymore. Not many. That's great. But, you know, it's still a summary of this longer conversation. Customer service, customer care. That's really where we see it. We see it more in administrative tasks than clinical today because they're not quite there. The hallucinations just can't happen if you want to use Gen AI in healthcare, specifically at the point of care. And I know last fall, I don't know if his opinions changed. Dr. John Halemko is the head of research up at Mayo. I've known John 20 years because he was here at Brigham and Women's in Boston for the longest time. Brilliant, brilliant man, gifted speaker. I wish I could present as well as he does. He's on record, on camera, saying these things are not ready for clinical care last fall. So you can do HIMSS TV, Dr. John Halemka, and it'll probably be the top hit you'll get. So it was recorded via the Healthcare Information Management System Society, where I used to be a board member. So that ability, he says that right there at clinical care, that doesn't mean there's not clinical usage. And it is really administrative. Where can we just take cost out of the system? Because you know what? Here's a good one. You want to know why you need to take cost out of the system? Let me grab this from today. Throw this up here. Hey, by the way, let me blow this up so everybody can see it. If you're not doing Medicare Advantage efficiently, it's going to cost you money. So some of everyone's 401k probably took a hit today, unfortunately. Sorry, because the rate of increase wasn't enough. They only went up 3.7%, which is effectively a decline. So guess what you need to be? Efficient and take better care of you. I was just reading this story like during our 5-minute break. So I was like, I'm going to leave this available because I thought it was cool. So this efficiency piece, wherever it may be, you need to deliver better health so you can reduce cost-effective care or just be flat more efficient. So I'll talk about some fun efficiency use cases now, and I'll dig into a couple of them from here. So get back to the presentation. So customer care, customer experience. Back to that Medicare Advantage piece. This is driving the industry, period. Every health plan wants to get better at this. United Healthcare, Humana, Anthem, Aetna are already good at it. HCSC, which is Blue Cross of Illinois, Texas, Oklahoma, North Dakota, New Mexico, just paid $3 billion to buy Cigna's Medicare business from them. This is big money for health plans and delivering care, but they're on a fixed income. They will change for a buck. I hate to say it. I mean, for a few dollars less a month, they'll hop Medicare Advantage plans because they can. Good for them. They have the right to choose. So when they call in, here's the problem. Your customer service folks who don't know healthcare are turning over at 30% in the first 6 to 9 months. Or turning over annually. They have a 30% annual turnover, takes 6 to 9 months underneath it. it's millions of lost. Like you spend 6, 9 months training somebody and they're so frustrated because they can't answer someone's question when they're on the phone. And sometimes they're sitting at home working remotely, trying to log into 15 systems to say, how many more PT visits do I have? I'm in pain, etc. And then when you track them, it's because they're hunting and pecking for information across all these systems. It's administratively a disaster. This is a great use case and one we've been doing for a long time. So this is nothing new. I have the Sydney mobile app from Anthem on my phone. The experience I get on my phone and I get on the Anthem portal is exactly the same. I have a son with a chronic, he's graduating college in a couple of weeks. Yikes. With a chronic disease we've had to manage that we didn't know anything about when he was diagnosed in junior high. I haven't had to call them in 5 years. I get everything I need with conversational AI on the portal or on the app. They're fantastic. That's 5 million calls that we deflect every year, never even go in. Now the agents on the other side are using the exact same technology where we're generating responses to help them answer benefit questions. And their average handle time is going from 3 minutes to 30 seconds. They can answer a question. Talk about a job satisfaction. 3 minutes trying to hunt and peck to 30 seconds. Did I answer your question? Yes, you did. Thank you. Going to lower turnover, going to drive efficiencies, just flat take cost out of the system. So this was conversational AI chat. Humana was voice, answering provider calls. So when HCA calls Blue at Tennessee to say, hey, you didn't pay this bill correctly, the voice is answering that at Humana. And they call Humana, excuse me, to get this answer. The interesting one about this is we were piloting this pre-COVID. The pilot was 147 practices that we didn't tell them we turned it on. Talk about a real pilot. It was either going to work or it wasn't. It was going great. We started to plan to scale. And then this funny thing happened called COVID. A lot of Humana's call centers are in the Philippines. You know what the Philippines doesn't have is an infrastructure to let people work from home. So we just had to turn this thing up. Basically just turn the volume up and say, boy, we better get this right because there's not enough people to answer calls. And then CVS was a fun one. If you got a vaccine at CVS, however you scheduled it, we built that in 3 weeks. And then their stock went up. Karen was quoted as saying same store sales growth went up because of people coming in for COVID shots, guilty as charged. I bought blades, razors, etc., razor blades, shaving cream, etc. I had to wait for my 10 minutes for my booster, my second shot. Works. So at scale, conversational AI just adds so much value right now. This is where we see the most efficiency is providing these rapid generative now use cases to answer questions in a more human-like fashion. I've actually heard some of our voice versions too. It's kind of scary, actually, how real some of these conversations sound when you put a person to it. The other one is you have this very long conversation. This one's in pilot, not in production yet, so I don't have a slide on it. So you call up and you have a couple-minute conversation because you have a health issue. So you're nervous, you're worried, you're confused, you just got discharged, you have pages of notes, you're trying to clarify it. And you're sitting there with your pen, listening to what the customer service person's telling you. And they say, do you understand? And you go, uh-huh, and hang up. What if we generate this nice, clean, 7-bullet summary of a 5-minute conversation in Spanish and give it to you in email as a follow-up? These are the type of efficiency, these are the fun type of use cases we're seeing. Cost out of the system, stickiness, that experience, especially when people, I think discharge is huge. We had this conversation with an in-home dialysis company recently, and for those of you who don't realize it, so if you go to in-home, so dialysis is terrible. Please, no one get kidney disease. I've done a lot of work with Fresenius, DaVita, Baxter. Like I've done I knock on wood, hope I never get that disease. If you crash into end-stage renal disease, dialysis, you have a 50-50 shot of making it 90 days. Coin flip. Not very good odds. So if you do in-home, you go home with this port, you go home with a 147-page manual on how to care for yourself. You get a 25, 30-minute instruction one-on-one. You just had surgery. You and your family members, caregivers, sometimes you're by yourself. The nurse goes, "You good?" Yeah. No. The steps to this, if you don't do one step or wash your hands correctly in the right order before you put the gloves, you have to start all over when you're changing your home stuff. We were able to take a 147-page document and on the fly start generating answers to questions. We called it a demo without walls. So like we didn't ingest theirs. We found one from Canada from a different vendor, brought it down and said, start asking questions. Let's see what comes back. Without tuning it, without training it, without touching it, just using Llama and our platform, it was pretty accurate, actually. So this idea of where can you change someone's experience, the use cases are almost infinite, but you have to be accurate. This one, my personal vendetta, prior auth. We all hate it. Everybody deals with it. We've all had to get prior auth for a medication or procedure or this or that, whatever it may be, your parents, your kids, we all hate it. There's laws coming. CMS 0057 dropped in February. Was that early March? February. About speed to prior authorizations for Medicare, Medicare Advantage, CHIP, and Medicaid patients. None of our health plans are ready to do this. They don't have it. They don't have the infrastructure, the technology. They don't have the automation in place to do it. I love the fact that we're trying to do this because I hate this thing. We all have had like nobody, patients don't like it, members don't like it, doctors don't like it, the health plans don't like it. It's like this necessary evil. And the other thing is right now, a lot of their processes were designed to be manual, not to be electronic. So we have to help them. You have to help them as you're talking to them as the next generation of leaders here, help them understand that they need to change what they do. Because if you automate a bad process, you just do it faster. Doesn't mean you did it better. So you start thinking about these intaking. You have structured, you have unstructured, you have big, long notes from clinicians coming in about what, why, and how. And then where do you put this in to match the criteria? There's 152 different comorbidities in the list for bariatric surgery. You got to have one of them. You don't need all of them. You got to have at least one. Severe obesity, you need to have, and then you need to have something like the list goes on. You can Google it. It's out there. That's the nice thing. The Medicare stuff is publicly available. But yet, when you create a Medicare Advantage plan, you can change it. The nice thing about healthcare standards is they're flexible. I was an HL7 programmer. That's a technology integration joke. Because the first 10 years of my career, all I did was customize HL7. Yeah, I broke it. My bad. Sorry. But we look at fire, and all this has to be tied to fire, which no one's ready for yet either. That's a different conversation for another day, not about AI. But when you think about this, once again, it's not always Gen AI that solves it. I'll take it different. I'm going to go to this one. Gen AI fits basically just in this little silver golf ball in the middle of taking documents and comparing them. This is all old-fashioned integration, 270, 275, 278, FHIR, APIs, US core. There's a lot of processes. Back to my, do you need Gen AI to solve everything? No, you don't. It fits in part of a solution back to empowering workers. So as you think about where in the various processes of prior auth on both sides of the house, can you use advanced technologies like generative AI or traditional technologies? So this is, for example, creating that clinical bundle, reading the unstructured note to extract out facts that they didn't put in the structured form. So much time is lost there going back and forth. That's where generative AI can come in. You're not making a clinical decision, you're just exposing information. The other important thing around transparency here is you can just look at health plan lawsuits, AI, Cigna, UHG, Humana. They're all getting hit because people are now accusing them of using AI to deny claims, deny prior authorizations, deny care. And the numbers they're getting sued with are massive. Back to that idea of regulating. So as we look at these things, you have to quickly, what we're talking about is don't let AI make the decision. That's our recommendation. Health plans are going to do whatever they want to do. Our idea is make everything more efficient so that a clinical person reviews it, because that's what's supposed to happen legally. So I think the Cigna one was more of an Evernorth. The American Medical Association sued early this year or late last year, Cigna, Evernorth, on medication. They denied 300,000 medications using AI, blah, blah, blah. We went after the money and you can't do this. I laughed when I read it. There's no AI in that thing. It's business process management code, if then else, they wrote in like 1982 on a mainframe. Now, hey, we like mainframes and COBOL. We're IBM. We're big fans. Because every pharmacy claim and almost every healthcare claim runs on them. In case you're wondering, plenty of room for COBOL skills these days. It's an advertisement for the students. So, but that's a Gen AI use case I got coming up. But this idea of full transparency in prior auth, our thought is let's make it all transparent, and then you have your decision management system. We are not building one. We can provide you with one. So there's a lot of startups. If you were at the HIMSS conference the other week, I was not. 17 of them was enough in a row. I took a break and went skiing with my college kids. Everybody has an Automagic generative AI widget that solves prior auth. No, it doesn't. It's too complicated. There was one company that hired one of the engineers that developed the landing system on the Falcon rocket, which means a gentleman was smart enough to design a system to take an object falling from space and land it softly on a floating piece of pad in the ocean so you could reuse it. He said he can't fix prior auth. It's too broken. He left. I'm not kidding. Rocket scientists go, this thing is, you guys are a mess. I'm out of your industry. But where in this step can we find efficiencies? There's no right or wrong answer. But like I said, vendors, clients, members, employer groups, everyone's asking each other now in writing, what are your governance processes? What's your trustworthiness? Quick commercial. This is what we do. We have our own AI tool, our own data tool, and the governance tool. We're spending more time talking about governance, if you didn't understand it, because of the life cycle of this process. Where is it? Where do you want to go? All of these steps, we can talk through model deployment, model governance anytime, ad nauseum. I love this stuff, but it's about governance. Somebody asks, how do you monitor millions of parameters? There you go. But you do it all the way down. You automate it. So again, we're not telling you what you consider fair or where there's bias. We'll identify it based on every use case threshold. Because you may build a model for maternity care. It's going to be biased because there should be no men in that model. So there's times where bias is okay in a model, sometimes it's not. So as we're thinking through all of these things, as we connect all the dots, you can monitor it and set your thresholds. So when you start to think about evaluation and monitoring, the other thing we're talking about is being able to monitor your governance risk compliance, your GRC, around NIST, et cetera. Because when these regulations do hit, the EU AI Act, you actually automate their regulations into the program, GDPR, et cetera, so that you get the correct answer and are able to track it all the way through and alert people if you start to drift away. So not only just the data drift, the model drift, but legal compliance, regulatory drift. So we're really thinking about this at that enterprise scale, that people need to take a step back and say, okay, you already got, everyone's got great ideas. Whether it's actually a good one to look at is go look at NYU Langone. I was there a couple weeks ago. Actually, it was like 2 months ago now. You can Google NYU and then Tron, like the old sci-fi movie, one word, Nature magazine. They published their study. Great study. I read it on the train ride home from New York that day. They're just using generative AI to augment unstructured data into their successful readmission predictive models that they use every day. Great uptick, great this. When I was talking to the head of the program, this was his number one problem. He's been successful. He's only got like 20 people. He's been too successful. He goes, I can't keep doing this. I said, we can automate this for you, Dr. Yin. I don't want to disturb without disturbing anything you've already done. Let us take this part of the work over for you and automate 60, 70% of it and let your brilliant team focus on what they do every day. Because there's brilliant people here. It's the last mile that leaves people in pilot purgatory. We want to help people make sure they get to that last mile all the way through. So I'm going to pause, take a break, take a sip of water here. Comments, questions. If I can figure out how to find the chat, I would, but I don't, because like I said, I'm not a Zoom expert. That's the button I was looking for. If I stop sharing for a minute, so that's a lot of what we see to everybody in the industry from a macroeconomic view. Same thing, clinical trials. How can we study research? My thought, and this is where I take my official IBM hat off and say, this is where I hope we go. If you think about any of your anytime you've walked in or a family member's walked in, especially when they're really sick and you are all nervous and everyone's worried, your doctor, your clinical team, she walks up, reads the top 3 sentences on the screen, maybe even on her phone walking in, of what might be right or wrong, diagnoses you on the way in, and then only asks you questions to back up their already diagnosis. It's called the self-reinforcing perception bias. Anyone who's parents, you've done it when you're kids. When you know your kids did something wrong, you started, what do you mean the cookie jar is empty? They just vanished? You sure you didn't have any cookies before dinner? Like, that's the fun part of it. Like, clinicians are notoriously guilty of that because they don't have time. Imagine the concept of this screen taking Brenden, everything like Brenden, and in the past 100 patients like Brenden, I saw in the past 6 months, extract all that unstructured, because it's still going to be unstructured, pull it together and said, patients like Brenden with all these matching criteria, all these parameters, green, yellow, red, what you did. Not me. Oh, by the way, here's some of the latest research that goes with it. And that's what they look at. That's where this thing, I believe this can really go. And amazing. The same thing, you can empower patients with something like that too. Think about where you can go with that. Like that's where I hope we go. I know there's brilliant people working on it here and all over the world, but we got to get it trusted. We can't have hallucinations. It can't be wrong when we're doing clinical care. But when we get it right, boy, is it going to be fun, especially for the clinicians. Talk about bringing the joy back into the nursing, bringing the joy back into medicine. We have drops in nursing enrollment school. We have drops in medical school enrollment. Pharmacy, it's a crisis. There is not enough people going to pharmacy tech school. We don't have enough behavioral health psychiatrists anymore, because it's like, if we could bring that joy back to them, maybe more people would go back into it, because we're going to have a clinical crisis on a global scale, because we're stealing people from all over the world because we can pay more. Eventually, we're going to run out of people too. Boy, wouldn't that be fun? Sorry, see, that's the whole point. I get excited. This is what we want to do in this industry, but we have to do it trusted, transparent, fair. The bias is a real problem. Healthcare data is systemically biased. It always has been. All the initial research was meant for 40, 50-year-old middle-aged white guys who have jobs in insurance. We got to bend that curve. So, all right.
Okay.
Have a
Thank you very
question.
much, Brenden,
Oh.
Hey, team.
for the wonderful insights from the industry perspective and the works that's being going in IBM on the ethical AI side. We do have a short time left for the questions, but I have a question from the audience.
Yep.
How to automate the clinical care with the way moving towards precision to overcome bias and be mindful of disparity in response and outcome with care and treatment.
You know, and that's a great one. I was just kind of getting to that as a close. I think you typed it before I said anything. Is I was having this conversation with another health plan, call it a year ago, and they were very nascent. They got some small data science and they want to start predicting things. They asked a very similar. We were talking about a project we did in California, which has a massively diverse population, which was a great place to do work because of the nature of that population and how and what we did. And the woman on the team goes, "So can I ask a question?" So, yeah. How do you fix the fact that our data is systemically biased, especially in a state like ours where we have like 4 major cities and everybody's super rural and poor? I was like, that's not easy. She goes, "Okay, I'm sorry. I thought I missed something." We're like, no. There are tools, strategies. I'm sure you guys teach them about flipping data, rotating things, the way you do it and the way you prep the data, and then you test it and flip it around, make sure it doesn't come out wrong. It's not always tech. People have tech. We have tech. Amazon, Azure, everybody, Data Robot. There's great tools. There's so much technique that I'm sure that is taught in class. I wish I could say there's an easy button to that. There still just isn't. We just have to fix it. But that's where the transparency and the monitoring comes in. That if you agree it works, you better be monitoring it to make sure it doesn't drift off below a threshold and start scoring incorrectly, especially once people trust it. Even if it's just who's going to cost more money next month. You know, we think Destiny's going to, sorry, you're first in line, so we're going to pick on Destiny. You're going to cost more money next month. Why? Well, if that model starts to drift, we need to know. You got to automate that. That's probably the best recommendation.
Okay. Thank you, Brenden. There is another one last question for you from the audience. What ethical challenges arise from relying on AI for medical diagnosis and treatment recommendations? And how can IBM mitigate potential risks to patient autonomy and doctor-patient relationships?
Yeah, this is something. I actually was hosting a webinar on this the other day, and I actually had a lawyer on the phone with us also. We had another member of Francesca Rossi's team, another one of our AI ethicists, myself, and a lawyer monitoring. How do you think about this? Because it's when you start to bring the legal compliance into it, that's another thing that's slowing everything down. But there is a way to think about it. The ethical challenge is at what point are you clear? And our viewpoint in many other AI companies, not just, is we're here to augment the human experience. AI is augmented intelligence. At some point, especially in healthcare, I don't believe that we, IBM, are ever going to make a diagnosis. Because I will say it out loud, the lawyers will never take on that liability. We will second guess. I'm not second guess. We will second check. We did this years ago when we had an imaging company. We would be a second read on images. So image, doctor's report, AI reads the image and double checks. We were a second opinion especially on wet reads. The company, it's still called Merge. We don't own it anymore. We spun it off, but we put that in. But we didn't make a diagnosis. We did a fact check. And I think to the ambient microphone thing, I think there's a lot of hope there. And that's going to change an experience when you and I get to talk about our healthcare, and doctor's not over here doing this, typing away over a screen back at you. But like I said, we're talking about doing the governance behind it to ensure that everything is fair, biased, not, there's no problems with the tools that are generating the rest of the data that goes in the EMR. It would then be checked by the doctor. But how many times are they going to just cursory? Because the worst thing that ever happened was templated notes. Because if you look, probably every 50-year-old guy who goes for his physical, I bet their note looks almost 80% the same. Templated notes were the worst thing ever invented. They make their lives easy, but they don't use them correctly. So there is that part of the ethical. If we're going to start doing documentation for them, there has to be accountability that they actually do absolutely read that it was okay. They don't just go, yep, 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 click, 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 approve. That there has to be processes and accountability built in. Once again, there's so much people in process in this. The tech is fun and it's going to be awesome, but we need accountability on the people side of how they use it. So once again, there's no easy button tech-wise to do that. I wish there was, but I think these are some of the things that are causing us, especially in our healthcare world, to move a little slower than other industries. And that's probably a better question for the next speaker. I'm looking somebody, I think Matt, you just put in, or somebody put in, the next speaker is about clinical decision making and the ethics behind that. That the next speaker probably would have a better idea on that. We're like I said, as a company, we want to empower other people to do that. If NYU wants to work with us and start making diagnosis, that's going to be on them. We'll empower them and be like a governance person, but we as a company are not going to build anything that does that. It's not our expertise. We don't have enough we have plenty of clinicians on staff, but we're not Mayo, we're not Cleveland Clinic, we're not NYU or whomever, doesn't matter the university. They need to do this. We can empower them, but they're going to have to do a lot of that ethics work. So we can consult, we can advise, we can do strategy on helping them do it, but that's really our strategy, is to help others do this because they're really the experts in how to do it. Now, on the flip side, the thing we are doing, I'm going to pivot, look up Cleveland Clinic quantum computing. You want to see some fun stuff? That's some cool stuff. Complete custom drug development. The only quantum computer that we have that is not in an IBM or a government facility is at the Cleveland Clinic. And a real one. It's not a fake chandelier. That sucker's down at millikelvins at the bottom. That's a cool one. But we're still not making the diagnosis. They're doing cool research stuff. And by the way, they are looking for other academic medical centers to be part of the Cleveland Clinic consortium, and you can leverage that compute power with them. I have nothing to do with that. If you want to go play and fold proteins at the quantum scale, we can connect you with the right people.
Okay. Thank you, Brenden, for a wonderful talk and your insights. I think we will definitely connect with you to discuss more about the potential collaboration in terms of research and when we are building our institute. With that end, I think we will go with our next speaker. So thanks a lot, Brenden, and
you're very welcome. Thank you, everyone. I really appreciate it. On behalf of IBM, thank you for inviting to this. We appreciate it. We need public-private partnerships. We need to get the next generation of diverse data scientists up and running. So happy to be here. Thank you so much. And I have to run to a client meeting I'm hosting. So I appreciate the time, everybody.
Sure. Thank you. Yeah.